Do you want to do it? Slow అయిపోయింది రావాలి అంతే మార్చినారు నాకు మార్చిన తక్కువ సో Hello, good morning. Anybody?
Good morning, sir.
Morning. So today we will be talking about the hemorrhoids, a little bit larger class, longer class. When the time is up, you just inform me 5 minutes before so that I can conclude. Some of you can inform me. So while discussing the anatomy of the anal canal, we talked a lot about the muscles as well as the mucosal modifications which aid in the continence of the anal canal. There we have discussed about the 3 cushions, anal cushions, which will help to completely block, which will act as a gaskets or which will act as this, what do you call them, the rubber ones, washers, preventing even the escape of the gas. So if these anal cushions by some reason they enlarge in size, they swell up, they will prolapse out of the anal canal, leading to a lot of problems. This is one of the more common anal disease the patients present to us in the surgical OPD. What are these hemorrhoids? What are these piles? Both are same or different? Both are same. The spectrum of the names confirm the spectrum of the disease. Initially, when there is only bleeding, when the patient has only rectal bleed, fresh bleed, we call them as hemorrhoids. And later on, when they form a mass and prolapse out of the anal canal, so that the patient can feel them while cleaning, we call them as masses or piles. Both are same, pertaining to the spectrum of the disease. The types, primary or idiopathic hemorrhoids, where the cause cannot be identified, and secondary to known to a definite cause. That is depending upon the etiology and depending upon the location. We can divide them into internal, where the masses lie within the anal canal which cannot be seen outside. External, the masses are present at the anal wart covered by the perianal skin. When both are present, we call them as internal and external. In this picture, you can see, you are seeing the dilated veins at the anal wart. You can see a mass-like thing in the perianal region. Nothing is there inside. You call them as external hemorrhoids. Here, the anal wart is normal and there is dilatation of these veins internally prolapsing outside. We call them as internal hemorrhoids. When both are present from above to below, we call them as internal and external. If you recollect the anatomy of the venous plexus in the submucosa of the anal canal, it definitely forms 2 bulges, 2 localized plexuses. One is just above the dentate line, which is called as internal hemorrhoidal plexus, and one outside the anal wart at the underneath the skin, we call it as inferior hemorrhoidal plexus. When this plexus dilates, we call it as external hemorrhoid. When this plexus dilates, we call it as internal hemorrhoid. If you see this picture carefully, you can follow the course of the vein. Here it is submucous. As it goes up, it passes through, pierces through the internal sphincter muscle and goes outside. When you go to the rectum, the veins will be in the subserous plane, whereas in the anal canal, they are in the submucous plane. Meanwhile, in between, they cross through the muscle. When the muscle contracts, when these muscles contract, there is constriction over this muscle. So the pressure here will increase, leading to dilatation and varicosities of these veins. The internal hemorrhoids are dilated internal hemorrhoidal venous plexus within enlarged and displaced anal cushion. So this is nothing but dilatation and varicosity of the venous plexus which are present in the anal cushions. Characteristically, they lie 3, 7 and 11 o'clock positions. When you keep the patient in lithotomy position in the operating table, we see these hemorrhoids at particular fixed places, 3, 7 and 11 o'clock positions pertaining to the arterial supply of the rectum. That you can understand here. So the superior rectal vein, as it descends down, divides into two branches, left and right. Left branch continues as one, which forms the 3 o'clock hemorrhoid. And the right branch divides into again two, anterior and posterior. Right anterior forms the 7 o'clock, right posterior forms the 11 o'clock position of the hemorrhoids. So depending on this anatomy, we see the hemorrhoids in fixed places in case of primary hemorrhoids. Of course, you can see secondary hemorrhoids, small in between hemorrhoids also you can see, which depend on the other tributaries of the vein. So in this picture carefully, this is the rectal mucosa, pinkish rectal mucosa or anal mucosa above the dentate line. This is the dentate line, junction of the mucosa and the skin. So this is the internal hemorrhoidal mass. Another 7 o'clock mass and 3 o'clock mass. This is the junction of the skin and the anoderm and this mucosa. You have got small similar swellings which are secondary piles. Here is one and here is a smaller secondary pile. These three are the primary piles and these are the secondary piles. This is the dentate line. So this is the anoderm which has been prolapsed. The external hemorrhoids are dilated venous channels in the inferior hemorrhoidal plexus here. When the veins of the anal verge they dilate, they form the external hemorrhoids. When both are present, extending from the anorectal ring to the exterior, we call them as interno-external piles. Coming to the etiology, we have discussed that there are of two types. One is primary or idiopathic, where the definite cause is not found, and secondary. The reasons explained for the development of idiopathic or primary internal hemorrhoids are hereditary factors, where the hemorrhoids are in families. The father and mother has the complaint of hemorrhoids. The children also are likely to get these complaints because of their peculiar anatomy, where the veins of the rectum and anal canal may be having thin walls which can dilate very easily, or the arterial supply to the rectum and anal canal will be so profuse that more blood goes there, leading to dilatation of the veins. These are the hereditary factors which predispose. And morphological factors. This pertains to entire humanity or bipedal organisms, where we walk on 2 feet. The stance of the body has become erect. Because of this process, and because the veins of the portal system, the veins of the suprarectal veins do not have the valves like the veins in the lower limb. In the lower limb also you are erect, the veins are erect, but the valves will help to propel the blood towards the heart. But in the portal system, veins are not present, valves are not present. So in erect position, the entire weight of the blood that is present in the portal system, starting from the porta hepatis to the lowermost vein in anal canal, the entire weight of the blood has to be borne by the rectal veins. So they are likely to dilate so much. Another anatomical factor is they pass through, the veins pass through the muscles, internal sphincter, just above the anorectal ring. So when the muscles contract, automatically the veins are get obstructed, leading to more pressure in the veins, more pressure in the submucous veins. So these are the three anatomical or morphological factors which are present in these people who develop hemorrhoids. By these simple reasons, they do not develop the hemorrhoids. They are predisposed. Okay. Then when some exciting cause is added to these anatomical predisposition, those people, they develop the hemorrhoids. Not all the people who have got these hereditary factors develop hemorrhoids. That has to be precipitated or excited by some other reasons. What are these exciting causes? The exciting causes what do they do is they cause straining, which will descent and swelling of the anal cushions. So these exciting causes which induces straining by the person will make the anal cushions to descend and swell up. So by the repeated process of this descent and swelling up, these anal cushions, they bulge up and form the hemorrhoids. The exciting causes commonly identified are constipation, overpurgation, dysentery, benign prostatic hypertrophy, and stricture of the urethra. In all these conditions, to empty the bowel or to empty the bladder, the person has to strain a lot. This straining, more intra-abdominal pressure and pushing down or bearing down of these pelvic contents will cause the descent and dragging of these anal cushions downwards and congestion of the venous plexuses, predisposing for the hemorrhoidal development. And the current view of the primary piles is again the same thing. The shearing forces acting on the anus lead to caudal displacement of the anal cushions and mucosal trauma. Whatever may be the reasons, anatomical, morphological, and other predisposing causes, excited by some other cause, all these things they lead to pushing down of these anal cushions, which will lead to the development of the hemorrhoids. So currently the theory is shearing forces acting on the anus lead to development of the anal hemorrhoids. And secondary causes, the most important, most dreadful cause of these hemorrhoids is carcinoma of the rectum. Whenever you examine the anal canal of the rectum, for any complaint, your idea, your aim must be to rule out the carcinoma of the anal canal and carcinoma of the rectum. The other causes are local deformities like anorectal deformity because of pelvic descent or poor perineal muscles, hypotonic anal sphincter, ascites leading to raised intra-abdominal pressure, and pelvic masses like gravid uterus, uterine neoplasms, fibroid, carcinoma of uterus cervix, etc. Ovarian neoplasms, bladder carcinoma, any space occupying it in the pelvis can increase the venous pressure and cause the anal hemorrhoids. And neurological causes like paraplegia and multiple sclerosis. Whenever the patient is paralyzed and abdominal lower half of the muscles are paralyzed, they lead to dilatation of this one. It may be because of constipation or something, weakness of the muscles. They are predisposed to develop the hemorrhoids. But in all these conditions, the primary complaint may not be the hemorrhoids. They are suffering with a larger disease, bigger disease, and when you examine, you may find dilatation of the anal veins known as hemorrhoids, but it is not the primary complaint. So in this picture, you can clearly see there is a growth in the rectum leading to obstruction and dilatation of the anal canal venous plexuses. Coming to the pathology, the hemorrhoid can be divided into pedicle, internal hemorrhoid, and external hemorrhoid. The pedicle is the part which is the beginning of the hemorrhoid, which is at the level of the anorectal ring, covered by the pink rectal mucosa. Internal hemorrhoid is the main part of the hemorrhoid, which is below the anorectal ring and extends up to the dentate line. And external hemorrhoid is the part which is covered by the skin, which is our anoderm, which is below the dentate line. The part below the dentate line is external hemorrhoid, The part between the dentate line and anorectal ring is the main hemorrhoidal mass or internal hemorrhoid. The beginning part is called the pedicule of the hemorrhoid. So you have to identify all these parts, because when you are planning to inject when you are giving sclerotherapy, you must clearly identify the part called as pedicule. There only you have to deposit the drug to cause the sclerosis of this pedicule or the veins. Depending on the extent, size of the hemorrhoid, they can be divided into 4 degrees. The first degree, they are very small, they bleed only. Whenever the patient strains, some blood comes out of the anal canal and you cannot see any mark, there is no collapse. Second degree, the masses are increased in size, they come out of the anal canal when strained and go spontaneously inside when the pressure is decreased. And third degree, they come out and they do not get reduced spontaneously, but they have to be replaced manually. The patient has to push them inside to avoid the discomfort. That is third degree. They prolapse but do not reduce spontaneously. The fourth degree is permanently prolapse. Even the person reduces them, again they come out. So they stay outside. The picture I have shown you, it belongs to fourth degree hemorrhoids, which have prolapsed and they are remaining outside the anal canal. So depending on the size of this extent of these hemorrhoids, they can be divided into 4 degrees. Why should you divide them into 4 degrees? Anyway, they are hemorrhoids. To plan the management, to select the management strategy, you have to divide all these things. For certain degrees, you can go for sclero. For certain degrees, you can band. For certain degrees, you have to go for excision treatment. So to decide about the treatment strategy, you have to divide them into certain degrees. Coming to clinical features, the principal and earliest symptom is bleeding, bleeding, bleeding. The patient says, whenever I visit the bathroom, the first thing I pass is the fresh blood, but there is no pain. Or at the end, he may pass again blood. When the rectum is emptied, and still the patient strains, he bleeds much. So bleeding is the principal and earliest symptom. So there are so many causes of this bleeding per rectum. How to decide whether it is due to hemorrhoids or due to other causes? Here, the blood is separate from the motion. It is not mixed with the stools. So you should ask whether it is mixed with the stools. Blood mixed with stools is a feature of dysentery. It is not a feature of hemorrhoids. So your blood is not mixed with the dysentery. It occurs as a fresh splash in the pan. When the patient strains, he passes a splash of blood on the pan. A fresh, brightly red blood having no mucus, no pus, no necrotic tissues. Necrotic tissues will be passed in case of carcinoma of the rectum. And if this continues for a long time, patient becomes anemic. This is one of the cause of the surgical causes of anemia. No other symptoms, the patient presents with anemia. He lands up in the medical department. When they investigate the cause of the anemia, they will find a hemorrhoidal mass bleeding. So other causes of surgical causes of anemia are esophageal causes. Esophageal varices or Barrett's esophagus, or peptic ulcer, carcinoma stomach, or the blind loop syndrome in the small bowel, ileorectal masses, ileocecal masses. All these things they present with anemia, and when investigated, we find the lesion. So hemorrhoids also, long-standing hemorrhoids are also one cause for the surgical cause of the anemia. The second complaint being, usually there will be no pain. Hemorrhoids, uncomplicated hemorrhoids are painless. Only bleeding will be present. When the patient says, I have got pain also, you must suspect some associated painful condition like fissure, like fistula, etc., like perianal gland inflammation, etc. And when you do not have any other reason, you must suspect complicated hemorrhoids. When the hemorrhoids are complicated with thrombosis, with strangulation, etc., they complain of pain. So painful hemorrhoids indicate associated painful conditions or complicated hemorrhoids. And masses. Some people complain of mass per annum. When you examine, you find there 3 masses on 3 sides of the anal opening, which are nothing but collapsed piles or external piles. Another one is anal irritation. You have seen in that picture the rectal mucosa is outside. So rectal mucosa secretes mucus and makes the perianal region slimy or wet. It leads to irritation of the perianal skin. And because the anal cushions are outside, they do not completely close, they do not completely seal off the anus. So there will be some leak of the anal contents, soiling the perianal skin and again causing the irritation. And because of these masses, the cleaning of this region is not proper. Certain amount of some little bit of fecal matter will be there, which again causes irritation. So the anal irritation can be due to irritation of the perianal skin by various reasons. This is the 3rd-degree hemorrhoid which has come out and which has not reduced spontaneously. So how do you investigate a case of hemorrhoids? The first and foremost thing is clinical examination. I said while inspecting the anal canal, once you see what you can see in the perineum, you ask the patient to strain or bear down. So this maneuver will bring about the hemorrhoidal masses outside. The 2nd-degree hemorrhoids, they come out. If there is rectal collapse, it comes out. If there is interception, it comes out. Without this maneuver, you are likely to miss all these 3 important diagnoses in examination of the rectum and anal canal. So when you ask the patient to bear down, you can see masses coming out of the lesion. Next one is digital rectal examination. Digital rectal examination reveals the hemorrhoids are not palpable. They are just dilated veins. When you press your finger on them, they collapse. You cannot feel a vein because it is collapsible. It is not an artery. Unless they are thrombosed. If they are complicated, if there is a thrombus in the veins, you can feel the thrombus. Usual hemorrhoids, uncomplicated hemorrhoids are not palpable. So why you should do the digital examination? To find whether they are complicated or not, and to find whether there is any predisposing mass in the rectum lumen. So you pass your finger as high as possible and try to feel the lower half of the rectum for any growth there. You must always rule out presence of a mass in the rectum in case of hemorrhoids. Then proctoscopy. We should do the proctoscopy to visualize the hemorrhoids, which is followed by sigmoidoscopy and colonoscopy to examine the proximal part of the colon. After digital examination, you pass a lubricated proctoscope into the rectum, throw the light into the proctoscope, gently withdraw the proctoscope. As you withdraw the proctoscope, as the tip of the proctoscope comes just down the anorectal ring, the hemorrhoidal masses will bulge out into the lumen. You can clearly see them as bluish colored venous masses. When you retract them, when you withdraw the proctoscope only, because they are collapsed, they are compressed and collapsed with the proctoscope. And when you withdraw them, they bulge out into the lumen and you can see the hemorrhoids. So this is the picture of proctoscopy. You can clearly see the 3 primary hemorrhoids bulging into the lumen of the proctoscope. On the left side, you have got the 3 o'clock hemorrhoid, which is on the left side. Right anterior, you have got 11 o'clock. Right posterior, you have got the 7 o'clock hemorrhoidal masses, which should be followed by sigmoidoscopy or colonoscopy. colonoscopy is ideal. If not available, at least you have to go for the sigmoidoscopy, which is advisable in all the cases. Why you should worry about the proximal colon? To rule out the rectal diseases, concomitant, simultaneously present rectal diseases. Patient may be having ulcerative colitis along with hemorrhoids. He may be having polyps. He may be having carcinoma. So if you neglect these major diseases and treat only the hemorrhoids minor disease, patient may blame you that you have missed my diagnosis. If you miss ulcerative colitis and if you miss polyps, nothing will happen. You can treat him afterwards. But if you miss the carcinoma, it is very dangerous. Because you yourself are spreading the carcinoma into the other parts of the colon. Hitherto, the mucosa is intact. Along with the fecal matter, the carcinoma cells which are coming down, they are easily passed outside the body. Now, by doing the hemorrhoidectomy, you have created a raw areas in the lower part of the extremity, and when the cells pass through, they easily get implanted into the anal canal, the wounds of the anal canal, leading to spread of the disease. From the anal canal, they can spread to the inguinal lymph nodes, another dangerous lymphatic field. So the disease completely becomes inoperable and incurable. So this is the reason why you must always examine the proximal part of the colon by colonoscopy or by sigmoidoscopy. If nothing is available, at least barium enema has to be done in suspected cases to avoid the danger of implantation of this setting cells. That you should not forget. So after proper investigation and confirmation of the diagnosis, and you have decided to treat the patient, you thought the patient needs treatment, then you start the treatment of the pile. The first and simplest treatment of the piles is conservative management. Before beginning any type of treatment, exclusion of the colorectal malignancy is the first priority. You should not forget. The first thing you must do is normalize the bowels of the person. Without doing this, whatever procedure you do, it's going to be a failure. The patient again strains a lot and there will be recurrence of the same complaint. So before planning for any treatment, to see that patient normalizes bowel habits. It's a must prerequisite. How to normalize his bowel habits? Ask him only to evacuate with natural desire. Whenever the person gets the nature call, he has to enter the bathroom. Otherwise not. He should not go to the bathroom unnecessarily and strain a lot. That will lead to the engorgement of the veins and hemorrhoidal formation. And adopting a defecatory position to minimize straining. He must adopt a position which decreases the straining. So the squatting position is better than the Western type sitting position. In the squatting position, that muscle, what do you call that muscle? Puborectalis muscle, the sling of the puborectalis muscle completely relaxes, making the rectum and anal canal into a straight line, decreasing the angle, so that without much straining, the rectal contents will pass through the anal. In sitting position, Western type, this is relaxed only 50%. Certain amount of angle will remain and patient has to strain a lot. Then give him some stool softeners or bulking agents or laxatives, lactulose, primafin, isopula has something to encourage the emptying of the bowels, or some creams or some suppositories. See that the person learns the habit of normal bowel movements. Then the treatment models available for us are the anal stretching, Lord's procedure, sclerotherapy, banding, and certain operative procedures. Anal stretching can be done in early cases of the hemorrhoids in young people where the sphincter tone is small. While examining the digital examination, you assess the tone of this sphincter. When the sphincter is spastic, especially in young people, and the early hemorrhoids are there, you can advise anal stretching, which will stretch the anal canal. The person can pass the stools without much straining, and there will not be any brunt on the hemorrhoidal masses. And secondly, it can be used to relieve pain and discomfort in thrombosed prolapsed piles. The person comes with acute piles. The piles have collapsed, they have enlarged, they have become very painful. These are called as the acute piles. In such cases, if you do the anal stretching gently, the congestion in the prolapsed piles will decrease, the inflammation will decrease, and the person has great relief for the pain. But you must be careful not to damage the edematous sphincter. If you stretch more, the edematous muscle fibers of the sphincter will tear, leading to incontinence. Because of this danger of incontinence and uncontrolled stretching of the sphincter, this procedure is not usually followed for treating the complicated piles. The second acceptable treatment is injection sclerotherapy. The sclerosant solution. Sclerosant is a drug that induces sclerosis or fibrosis whenever injected. It irritates the tissues. It will not cause necrosis to the tissues, just irritate the tissues to produce more fibrosis. Such things are called as sclerosant. If it kills the local tissues, you should call it as poison. But this is not poison. It only causes inflammation, aseptic inflammation, and induces the fibrosis. This method can be adopted in first and second degree piles. First degree, only bleeding is present. Second degree, the pile masses comes out and goes in. Reduces spontaneously, so that it indicates the size of the mass is just adequate for injection. It is not that great. Submucosal injection of 5% phenol in arachis oil or almond oil or olive oil is injected 5 ml at one point. The aim of this procedure is to create fibrosis at the injection site, which will cause obliteration of the vascular channels. The veins will be constricted by the fibrosis, and the mucosa will be tethered to the underlying muscle. It will be attached to the underlying muscle. It will be fixed to the underlying muscle, so that whenever the person strains, the mucosa will not collapse. The anal cushions will not collapse. So there will not be further progression of the hemorrhoids. The sclerosants that are commonly used are 5% phenol in almond oil or some oil. Phenol causes irritation and aseptic inflammation. And why it is mixed with oil? Oil delays the absorption of the phenol and it will soothe the tissues. It will decrease the irritative effect of the phenol to a certain extent. And other agents that are used are the sodium morphiate and the quinine The most common thing is the phenol, 5% phenol. This is popularized by the Sergeant Clinton Mission of Illinois, America. The procedure is in awakened patient, no anesthesia is required. Keep him in left lateral position and direct vision from proctoscope. Inject 5 ml of the sclerosant into the apex of the each pedicle submucosally, underneath the mucosa, around the venous plexuses, using a disposable syringe, special type of syringe called as Gabriel syringe. And the patient is assessed after 8 weeks. If necessary, if anything remains, you can go for a second procedure of injections. This is the syringe that is used for doing the sclerotherapy. This is the place. You keep the proctoscope at the anorectal ring, gently withdraw it and see the pile mass collapsing to the lumen chest. So at this point, submucosally, you can inject 5 ml of the sclerogen solution. The complications are usually it is painless because you are injecting underneath the mucosa above the dentate line, which is insensitive to pricking and cutting. If the patient complains discomfort, that means your needle has gone more deep into the muscle, sensitive muscle. So you must be careful. If we inject too superficial into the mucosa, it will cause necrosis of the mucosa and ulceration. If you go too deep into the muscles and other structures of the pelvis, it is disastrous. It leads to pelvic sepsis, prostatitis, impotency. In women, rectovaginal fistula, a lot of complications will arise if we inject too deeply, inappropriately. So you must be very careful and just inject only underneath the mucosa. You can put the needle in underneath the mucosa, you can just lift the mucosa and check whether it is in the correct position or not before injecting. The second procedure is banding. Banding is another procedure. If the pile mass is a little larger and bulkier, the sclerogen may not work. You need to inject more amount of sclerogen with more complications. So it is not safe. So in such cases, you can constrict the neck of the pile mass by tying it. How do you tie this? You cannot pull out the hemorrhoidal mass and apply a thread with tying. So that is not possible. So for this, a special instrument has been devised, which is called as a bander. So this you might have seen in the laparoscopic tubectomies in the gynec posting, in the family planning. They will be passing these rings, rubber rings, to do the tubectomies. The same mechanism also works here. This is done for second degree piles which cannot retract by themselves. And third degree hemorrhoidal masses, which are smaller in size, can also be banded. The instrument is called as Barrett's bander. It slips tight elastic bands onto the base of the pedicle of the hemorrhoid. So you pull the hemorrhoid, you pass these tight bands onto the neck, which will cause constriction, a sort of strangulation. So one complication of the hemorrhoids is strangulated hemorrhoids, where the neck of the hemorrhoidal prolapse hemorrhoid is nicked by the lower end of the sphincter. But here, this is a sort of internal strangulation, artificial or iatrogenic strangulation of the mass, which will lead to ischemic necrosis of the pile mass within 10 days. Afterwards, the pile mass falls away, leaving behind a small ulcer. And sometimes this ulcer may bleed, called as secondary bleeding. You must warn the patient if he gets any bleeding after 10 days, he should immediately return for control of the bleeding. So this is the Barrett's bander. This is the instrument to thread this, to load this instrument with these bands, a banded hemorrhoid. So here you can see clearly, this is the instrument. It is loaded with the bands here, and with another instrument, the hemorrhoidal mass is pulled into the lumen of this instrument, and bands are pushed. The bands are pushed onto the neck of the hemorrhoid. That will lead to necrosis of the part beyond this band. In 10 days, it falls away. So here also you can clearly see how it is pulled and band is applied. Another methods of non-surgical methods of dealing with hemorrhoids are cryotherapy and infrared coagulation. Cryotherapy, liquid nitrogen is applied to the pedicle of the hemorrhoid at minus 196 degrees, which will cause thrombosis and necrosis of the tissues there. It is equivalent to binding. And infrared photocoagulation, here the infrared rays will use heat for thrombosing the hemorrhoidal masses. All these things will be just like the banding. The hemorrhoidal mass will get necrosed after some time and falls away. But nowadays these two things are not used routinely. Now the remaining thing is the surgical methods of controlling the hemorrhoids. Early stages, early degrees, small hemorrhoids, you can go for non-surgical methods. When the hemorrhoids are third degree, fourth degree, when they are bulkier, then you cannot tackle them with sclero or with banding. The remaining option is surgical excision. When they are interno-external, when the skin is covering a part of the hemorrhoid, you cannot go for sclero or you cannot band it because it will be banding the skin is very painful. So you cannot go for banding. So the third degree and fourth degree hemorrhoids are the indication for surgical methods or operative measures. Then the second degree hemorrhoids not cured by non-operative methods. So if there is recurrence after second degree non-operative treatment, you can go for surgery. Fibrosed hemorrhoids, international hemorrhoids, and hemorrhoidal bleeding sufficient to cause anemia. When hemorrhoids are bleeding, the patient is anemic. In such cases, don't take the chance of recurrence and again getting the bleeding or anemia. In such cases, you can directly go for complete excision of the hemorrhoidal masses. So these are the indications for operative treatment of the hemorrhoids. What are the contraindications? Actually, there are no contraindications for hemorrhoid. Patients having a bleeding hemorrhoidal mass, you have to remove it. Why should there be any contraindication? Because to avoid the problems, post-operative problems, you must be justified in advising the operative treatment for this hemorrhoidal masses. The situations where there are relative contraindications are patient is already having fecal incontinence, and by doing this surgery, you are further aggravating the incontinence. So there is more disadvantage to the patient rather than advantage. So don't operate on fecal incontinence cases. This happens in women, elderly women, or obese people, or multiparous women like. The woman having rectocele, the rectovaginal wall will be very thin and the rectal mucosa will be, vaginal mucosa and rectal mucosa will be close. In such cases, you pull them along with the rectal mucosa, you are pulling the vaginal mucosa also and you create fistula, rectovaginal fistula. The danger of rectovaginal fistula necrosis is there, so don't operate. In such cases, patient having bleeding disorders, hemophilia, patient on aspirin, patient on thrombocytopenia, you must be very careful. Before operating, you must control all this coagulation profile and go for surgery. Patient with portal hypertension, never operate on patients with portal hypertension. They are not true hemorrhoids, they are rectal varices, they extend from the liver to the anal canal. Nothing is going to happen if you ligate only the distalmost part of the vein. Nothing will happen. There are a lot of complications. So you reduce the portal pressure by doing some definite procedure. The rectal varices will collapse. If they remain, then you can think of the hemorrhoidectomy and Crohn's disease, which will definitely lead to non-healing of the wound and fistula formation. So you must be very careful, though they are not absolute contraindications, you must be careful and judge the outcome. Judge the outcome and discuss with the patient the outcome, then you can go for these surgical measures. The technique is patient is given an enema and general anesthesia, real anesthesia is given. Patient is kept in lithotomy or prone jackknife position, prone position. In the European countries and in Asian countries, we adopt the lithotomy position for operating on hemorrhoids. In American people, they go for prone position, jackknife position, prone position. Perianal skin is shaved and formal examination is performed. Again, under anesthesia, you must do the digital examination, proctoscopy before putting your knife. Rule out any mass, rule out any other disease, then go for the hemorrhoidectomy. It can be done by open method or closed method. This says whether you suture the wound or leave the wound open. The remaining procedure is same. In open technique, which is common in UK or in other European countries, it is called as Milligan-Morgan operation or dissection and ligation and excision of the mass. Dissection, ligation and excision of the hemorrhoidal mass, which is called as Milligan-Morgan operation, or the closed technique. You dissect, you ligate, you excise the mass. Then the wound in the mucosa is closed, sutured. So this is called as closed technique, which is called as Ferguson hemorrhoidectomy. Ferguson hemorrhoidectomy, or a modified Ferguson called as Parks hemorrhoidectomy. Both involve ligation and excision, and the difference is in closing the mucosa. Other methods that are available for us to deal with hemorrhoids are Milligan-Morgan is one, Ferguson, Parks, Whitehead, clamp and cautery of Ferguson. Nowadays, you can apply clamps or staples. You can pull the hemorrhoidal mass at the base of the hemorrhoid. You can apply this stapler also. You can cauterize them with bipolar. You can cauterize them. You can thrombose them with harmonic scalpel. All sophisticated instruments without cutting or without incising this thing. And you have got the hemorrhoidopexy, and you can do the dearterialization. All these things are designed to thrombose or excise the hemorrhoidal mass, somehow obliterate the venous plexus. These are the pictures you can see. The three hemorrhoidal mass 3, 7, 11. They are caught with the forceps. They are dissected out. This is the classical open procedure, Milligan-Morgan procedure, using your index finger and pulling the hemorrhoidal mass out. Using index finger, you make the neck of the pedicule of the starting point of the hemorrhoid more prominent. Then give a nick V-shaped cut with scissor onto the skin, then dissect. You transfix the neck of the hemorrhoid. You excise the hemorrhoids. Once you have finished off the excision of 3 hemorrhoids, the wounds will look like these things. 3 leaves of a clover leaf. After surgery, if the wounds look like a clover, the trouble is over. If it looks like dahlia, it should be a failure. The meaning of this sentence is the wounds must be separate. 3 wounds must be separate. They must be separated by a normal ano-mucosal bridge and skin mucosal bridge. Must be separating the 3 wounds. This will not lead to the anal stenosis, a dreadful complication of hemorrhoidectomy. This is closed procedure where you are excising hemorrhoidal mass with diathermy and suturing the defect in the mucosa. Closed method, Ferguson hemorrhoidectomy. Another one is stapled hemorrhoidectomy. A special instrument is designed where you excise a circumference of the mucosa and submucosa, including the veins, just above the dentate line. And the defect in the mucosa is again approximated by suturing the rectal mucosa with the dentate. This is the instrument where he is taking purse string sutures. Through the purse string sutures, they will pass the angle. They will take the mucosal purse string suture. Through the purse string, they will pass the anvil of the instrument. This is the anvil of the instrument. Then the instrument is attached and it is fired. That will excise a strip of mucosa circumferentially and automatically approximates the rectal mucosa, with the anal mucosa with a stapler. With a single firing, you excise a hemorrhoidal mass, neck of the hemorrhoidal mass, all the 3 in a piece, and you suture the rectal mucosa with the anal mucosa. What is the advantage of this one? In this picture, you have observed the anal cushions are still in place. In open surgery, we pull them and we excise them completely. So no anal cushions will remain after operation. But in this, the anal cushions are still remaining. The anal cushions are remaining. That is the advantage. Another recent procedure is, nowadays they call the hemorrhoids as not as venous or disease, they call them as arterial disease. So while doing digital rectal examination, if you palpate carefully the pedicle of the hemorrhoid, you can feel the pulse, arterial pulse you can feel. So they say the hemorrhoids are due to increased arterial supply. If you can ligate this artery, the hemorrhoidal vessel will collapse. That is the basis of this de-arterialization. With the help of the Doppler, you identify the pulse where it is present and it is suture ligated. After some time, because the arterial flow is decreased, the veins will collapse and they get thrombosed and the hemorrhoidal mass will shrink. The postoperative care after hemorrhoidectomy, surgical hemorrhoidectomy, patient should take 2 warm baths, 6 baths each day, laxatives must be prescribed, analgesia should be given, and metronidazole along with the dry dressing must be given. After 3 to 4 weeks, you must do the rectal examination, and our practice is on the 3rd day or 4th day before discharging the patient, we do the rectal examination, though it is painful, to avoid the formation of the synechiae. After 3 to 4 weeks of the review of the patient, you do the rectal examination and assess the tone of the sphincter muscle and assess the stenosis there. The person is going to get the stenosis, you advise him anal dilator therapy. Anal dilator therapy should be advised to avoid the stenosis. Now, the post-operative complications are, they can be divided early and late. Early complications are pain, acute retention of urine because of the spasm of the sphincters and reactive hemorrhage. Late complications are secondary hemorrhage because of infection, anal stricture. If the wound does not heal properly, it can lead to anal fissure, and the dangerous one, the incontinence. At all costs, you must avoid the development of incontinence. This cannot be cured, this cannot be tackled properly. Remaining all complications, you can do something, but you cannot do anything with the incontinence. So be careful before advising surgery in persons predisposed for anal incontinence. Now a word about the complicated hemorrhoids. The complications that develop in the hemorrhoids before treatment can be hemorrhage, strangulation, thrombosis, ulceration, gangrene, portal pyemia, and fibrosis. Hemorrhage can occur out. There is one word called acute attack of piles. The person says, I was having nothing 3 days before, up to 3 days before, only since these 3 days I am getting painful mass in the anal region. Such complaint is called as acute attack of piles. It can be due to strangulated piles, thrombolectal pile, perianal or inflamed skin tag of an anal fissure. This is the strangulated hemorrhoidal mass. When they are bleeding, when the bleeding is severe, first you exclude the bleeding diathesis and see whether the patient is using any anticoagulants. And locally, you can apply the adrenaline compresses. You can give some sedation to the patient and give blood transfusion if necessary. If the bleeding is not controlled, get him to the theater and control the bleeding by suturing the piles. Other complications, strangulation, thrombosis, and gangrene, to operate or not to operate. The danger of meddling with these things is, in a good setting, is development of the portal pyemia and post-operative portal stenosis. So you are dealing with infected things. That the infective foci, the hemorrhage will directly reach the liver, leading to the dangerous, life-endangering condition called as portal pyemia. And you are meddling with the edematous sphincter muscle, which can lead to stenosis later on. And incontinence will be there. Because of these complications, most people do not like to operate in acute setting. The most we can do the anal stretching, gentle anal stretching, and allow the patient for conservative treatment. How to shrink the pile masses when they are collapsed? Give analgesics Give bed rest with foot and elevation, frequent hot baths, warm or cold saline compresses, glycerin maximum dressings. You heat the glycerin and add magnesium sulfate powder and make a paste. You soak the gauze piece in that paste and apply them. Glycerin and maximum being hygroscopic, they will draw out the enema fluid from the hemorrhoidal masses and they shrink and they retract, they go inside the anal canal. After some time, you can do the regular surgery for the hemorrhoids. And the last thing is external hemorrhoidal masses, which are nothing but a thrombosed external hemorrhoid known as perianal hematoma. The person does the unaccustomed straining. One of these venules in the external hemorrhoid ruptures and forms a small, well circumscribed hematoma. This will be very painful, of short duration. If the person comes early, you can give a cruciate incision and evacuate the hematoma and allow the ulcer to heal. If the person comes late, give him some analgesics and antibiotics, and so that the hematoma will get shrunk by itself. It gets fibrous, leading to the development of a fibrous hemorrhoid or a skin tag or anal tag. This is the external hemorrhoid, thrombosed external hemorrhoid. It has already burst and has released its clot outside, so it has shrunk inside. This will form a fibrous hemorrhoid or a skin tag afterwards. So with this, we have completed the topic of hemorrhoid, the most common topic. Any doubts, you can ask. There are no doubts. Thank you. We'll stop the session here.